Good morning, ladies and gentlemen, and thank you so much for asking me to present SipTilSend, the end of pre-surgical oral fluid deprivation, to you at the Australian and New Zealand Hip Fracture Registry biannual Hip Fest. My name's Dr. Matthew Checketts, and I'm an anaesthesiologist at NHS Tayside in Scotland. It's a great pleasure to be not here today, and I wish I could be here in person, but thanks anyway. I think the invitation to speak today, or give this presentation, came from a successful hipcast that I made with your team earlier this year, where we discussed our journey in Dundee and how we got to the point where we basically abandoned preoperative fluid deprivation for our patients. Very successful and a very interesting hipcast if you have time to listen to it. Dundee is a city about an hour north of Edinburgh on the east coast of Scotland. And I work in this large hospital called Ninewells Hospital, which has also got a medical school and a university block, and a nice view out the window onto the River Tay. Dundee's come up in the world over the past few years, and the Victoria and Albert Museum now has an outpost in Dundee designed by the Japanese architect Kengo Kuma. Quite dramatic, isn't it? So if you ever come across to the UK, come and see us in Dundee. We'd love to welcome you there. So Dundee's in the middle of the region, and we have two satellite hospitals, one in about 20 miles to the west, Perth Royal Infirmary, and one about an hour to the northeast, Strathclyde Hospital, which are both elective surgery hospitals. I've been an anaesthesiologist in Dundee since 1998, in fact 1996 if you include my senior registrar years. I trained entirely in Scotland, although originally from England, and during my training I did research with Gavin Kenny and Tony Wildsmith, who are both well-known figures in the academic world of anaesthesiology. My interests include hip fracture and trauma, regional and local anaesthetic techniques, enhanced recovery, day surgery, and intravenous anaesthesia. And I also sit on the Scottish Hip Fracture Audit, which is perhaps how you first learned of SipTilSend. A little bit about the history of fasting and anaesthesia. Joseph Lister was the professor of surgery in Glasgow in the 19th century, and he was the father of surgical antisepsis. He made a major contribution to that and hugely reduced post-operative infections. Anyway, he also knew a little bit about anaesthesia and surgery, and one of his quotes from 1883 was, "While it is desirable that there is no solid material in the stomach when chloroform anaesthesia is administered, it will be found very salutary to give a cup of tea or beef tea about 2 hours preoperatively." And he did that because he'd observed that patients who were allowed to drink close to the time of anaesthesia had a much lower incidence of post-operative nausea and vomiting than those who'd been fasting from fluids for a long time. So why did fasting come into being in practice? Well, it followed the work and the publication by Curtis Mendelsohn in the late 1940s of a series of 44,000 obstetric patients who'd had inhalational general anaesthesia for either caesarean section or vaginal deliveries. And out of those 44,000 patients that they'd had in their institution, 66 cases of aspiration and regurgitation had occurred, 0.15%. And of those 66 cases, 2 died rapidly because solid food materials blocked the airway. They became acutely hypoxic and died. The other 64 patients all recovered within 36 hours, with a brief period of respiratory distress secondary to the chemical pneumonitis caused by the aspiration. He also did some animal work which explained the pathology of the chemical pneumonitis and named it Mendelssohn's syndrome. So he postulated that depriving patients of fluids and food during labour might make things safer if they had to have an anaesthetic. So it seemed like a good idea. That was the level of evidence that was used to introduce fasting. No other evidence appeared. So nil by mouth from midnight became into common practice in the 1950s and beyond, probably simply because it was easy to write on the patient's chart. But as I said, there's little or no evidence that fasting for fluids, or food for that matter, reduces the risk or severity of aspiration. Excuse me. The physiology of gastric emptying has been known for well over a century, and fluids empty the stomach very rapidly with a half-life of 10 to 15 minutes. Here's a decay curve for someone who's taken a single bolus of a carbohydrate-containing beverage. The more you drink, the more rapidly that food emptying actually is. Another fallacy is if you add milk to drinks, it significantly reduces gastric emptying, because everyone knows milk is like food, isn't it? Because it contains fat and protein. Well, here's a study, one of many, that shows that adding milk to 50 mils of milk to black tea makes no difference to the rapid speed of gastric emptying. So if your patients want a hot drink with some milk, don't be afraid. It doesn't make any difference. So the current international guidelines for fasting around the world recommend a minimum fast of 2 hours for oral fluids. And this is a classic example of them being frightened to challenge the established wisdom that have been handed down from father to son, from textbook to textbook, from guideline to guideline. And they all say the purpose of fasting is to reduce preoperative regurgitation and aspiration. But somebody show me the evidence for that. It doesn't exist. So perhaps this is the ultimate example of medical sophistry. Sophistry is named after the Greek philosophers, the sophists, who tried to explain everything through logic, to make a plausible hypothesis. But it is in fact a fallacy. Classic. If you want to read more about the evidence and arguments of why we should reduce the 2-hour minimum fluid fasting, read this editorial published in the BGA in 2020 by Krista Morrison and others, where it talks about the history, why the 2-hour rule doesn't work because of the vagaries and uncertainty about when patients go to theatre, the physiology, the harm caused by prolonged fluid restriction and the morbidity, the many benefits and advantages of allowing oral fluids preoperatively and the better outcomes, and the lack of evidence that reducing the increasing fasting times reduces the risk. And lastly, a plea to those who produce guidelines to get up to speed and review the evidence in a more analytical way. So on the back of that, this is something I've been wanting to do for a very long time. Our story started April 21 when Hannah Watson, who's one of our wonderful senior charge nurses in our ward, did an audit of patients coming through our emergency theatre at Ninewells. And she found the mean fluid deprivation time to be a staggering 7.5 hours. Remember, the recommended time is 2 hours. And the maximum time was 22 hours, and it was very common for patients to be asked to fast on multiple days when their operations were cancelled or postponed, resulting in much patient misery, morbidity, and undoubtedly harm. It's a bit like asking someone to run a 10-kilometre race and not drink anything for 12 or 24 hours pre-race. How well do you think they're going to do? Are they going to finish? I doubt it, no matter how fit they are. So I said, look, the only way to break this problem is to go SipTilSend. And to my surprise, my colleagues agreed with me, perhaps for the first time in my career. So that gave us a mandate to actually survey all of my colleagues in the department, all 106 of them, and we asked them two simple questions. Would you be happy for patients to SipTilSend from an NHS glass of up to 170 mils per hour of water/clear fluids? 90% said yes, they would. Would you be happy for patients to have a cup of tea or coffee with up to 15 mils of milk on the morning of surgery? Again, nearly 90% said yes. Goodness me. Wonders would never cease. So that gave us a mandate to take this a bit further, because it's all well and good agreeing in your anaesthetic department what you're going to do, but you've got to get it through the governance processes in your institution. And I found out a lot about clinical governance during this process. We had to go through a 3-stage governance approval process. Stage 1 was easy, the Anaesthesia Clinical Governance Committee, because they're all on board. So our SBAR, our Situation Background Assessment and Recommendation document, which we use commonly for getting concepts and ideas across in the NHS in the UK, was rapidly passed. Next, we went to the NHS Tayside Clinical Guidelines Committee, because we were changing a clinical guideline, and we were doing something out with what national and international guidelines were saying. We thought that might be more tricky, but again, that was very rapidly accepted, and those on the panel quickly recognized this was a patient-centered change that would make a positive impact on patient well-being. We'd already started doing it in the orthopedic trauma lists, just by stealth, I guess, and you won't be surprised to learn it was extremely well received by our nursing staff, our patients, physios, and the clinicians. And interesting, as an aside, one of our slightly cynical physiotherapists took me aside one day and said, "Matthew, I want to talk about SipTilSend." And I thought she was going to tell me off about something. And she said, "I have to be honest, that we can see a definite improvement in patients' ability to rehabilitate the day after their surgery when they've been allowed to SipTilSend." These are frail hip fracture patients. And I thought, well, that's an anecdote, but it's a powerful anecdote from someone who wouldn't tell you something if she didn't believe it. So we took it forward, and we realized that we could extend this and launch it across the whole hospital and the 3 hospitals in our trust and all disciplines. So we put a lot of time into contacting all stakeholders, all surgeons, all physicians, all radiologists, anybody who's involved in any patient care that might involve, a previously a fasting guideline. We then updated the Tayside Fluid, Food and Nutrition Policy, a long, boring document that no one really reads, but it's got to be done. And that was approved by the NHS Tayside board. And then we had sign-off from the board that it was okay and safe to do this. That took several months, but was worth the work. Once we got that approval, we could really start planning the launch in earnest, and we spent several months doing that so we could do it in a structured and controlled way. So we engaged with a whole lot of people. We'd educated many people who we hired as SipTilSend champions, and these were generally nursing staff working in the wards. So we were all on the same page. We could all disseminate the information, and everybody knew what they were going to be doing on the day of launch, 1st of December 2021. Marketing is really important when you're doing this kind of thing. We developed this logo, SipTilSend, simple, safe, and kind. And I think that's important to keep the marketing consistent. And if you'd like to adopt SipTilSend, we'd be more than delighted to share this logo with you, taking our NHS badge off it, so you can do the same. It's important that it's called SipTilSend. It does what it says on the tin. And you won't be surprised to learn that there's been lots and lots of interest, both in the UK and beyond, for this. It's really gaining a lot of momentum. We developed posters, flyers, T-shirts, and all kinds of stuff to aid us in the launch. And here's some examples of some of the posters that we had in our wards for our staff, so everyone knew what SipTilSend was, what the rules were, so there was no confusion about who did what and when. And I think launching it in that way made it simple. Again, happy to share that with you. One of the toughest groups, obviously, to convince are actually the patients, because patients have a strong held belief that you must not drink or eat, for that matter, prior to an anaesthetic, because it might be dangerous, you might vomit. Everybody knows that. So we have to convince them that it's safe to drink, and we have to encourage them, and it's actually safer to drink. So here's a graphic that appears in one of the leaflets that we send to patients who are coming in for planned surgery. And the important bit is over here when they get into hospital. Once in hospital, you're encouraged to sip water until you're sent for your procedure. Sip, SipTilSend. So you must update all of that stuff and spend quite a lot of time educating and reassuring patients. Otherwise, they will default to not drinking. So, did it work? Did we achieve what we wanted to achieve? Well, I think the figures speak for themselves, don't they? Here's the median fluid fast time pre-SipTilSend and post-SipTilSend, from nearly 6 hours to 17 minutes. You'll never achieve that kind of success any other way than going SipTilSend. And this time is from last drink to arriving in the anaesthetic room. Similarly, all the work we put in educating our staff and our champions paid off, because here's an interview we did pre and post with our staff on the ward, whether they felt confident giving the correct fluid fasting time to patients before and after, their overall confidence with managing patients' fasting, and their need for more education. I think, again, the figures in the table really speak for themselves. The legwork we put in and all the Teams meetings we had with them multiple times paid off. They felt confident. And interesting, on launch day, we were all a bit on tenterhooks. We walked around the wards and we said, is everything going all right? And they said, no problem, no issues. And the thing that really made it gratifying for me was at the end of that first day, that Monday, I walked around every single ward in the hospital, and in front of every single patient was a glass of water. I thought, yeah, we've done it. We've cracked it. So, did we have any adverse events? That's the first question that people ask. It's all very well being gung-ho and reducing fasting, but is it safe? Well, we're monitoring it closely. We're using a Datex surveillance system. I'm sure you might be familiar with that too. And we've had 6 cases of regurgitation in the first 6 months, which is 6 out of 12,000 cases, which is about the sort of level of incidence that is reported in literature anyway. So the incidence has not increased. Regurgitation happens sporadically. It's a bit unpredictable. It's more common in emergency patients than planned patients. But the good news is that none of these patients came to any harm. They all went home the same day. And we actually think those who've been drinking and if they do regurgitate, the pH of that solution will be higher and less acidic, and the residual volume in the stomach will be less. And there is evidence to support that fact. So we think if regurgitation does happen, SipTilSend makes the outcome safer. But we're not complacent. We're monitoring on an ongoing basis, and we're continuing to review it every quarter. So we achieved what we wanted to achieve in Tayside. Great. It quickly took off in Scotland through the Scottish hip fracture audit, and before we knew it, just about every health board in Scotland had adopted it for their trauma patients, and many others had adopted it for all their other patients. So it's really growing arms and legs. Multiple other hospitals in the UK have come on board, and we've been helping to support them, and a number in the Antipodes as well. And we're delighted that this kind of forum allows us to raise the profile of this even further. The Scottish Hip Fracture Audit Group have been extremely supportive, as have the Scottish Arthroplasty team, because it's now become a standard for arthroplasty patients. And we've had lots of support from NHS Scotland, which is fantastic. The Association of Anaesthetists heard about what we were doing, and they've invited me to write an editorial on this topic, which I've just submitted. You'll be seeing that quite soon. And also to chair a working party to update the association preoperative fasting guidelines. That takes time, and it's a case of guidelines lagging behind clinical practice, but we'll get there. Momentum is growing. As I said, every board in Scotland have adopted it. Fantastic. Many in England have done the same. Many were doing it before. For example, in Torbay, they've been doing it for a decade in their day surgery unit without incident. And many in the Antipodes as well. So it's great, and I'm sure more will come on board. It's a no-brainer, isn't it, when you think about it and when you actually look at it analytically. But what really counts to me is the patient experience. And here's some feedback we got after SipTilSend, and this was from the daughter of her mother who had a hip fracture in our unit. And the quote I pulled out was, "Mum especially appreciated the SipTilSend initiative. Being able to keep her mouth comfortable right up to the point of theatre made such a difference to her." And for me, that's enough. That's what counts. So we would love to help and support you to adopt SipTilSend too, and have the confidence to do so. And here's all our contact details. And what I propose, because I can't be with you in person today because I'm 12,000 miles away, is for us to organize a live video conference with anyone who's interested, discussing this with us, and a Q&A with our team at a mutually convenient time, and give you a chance to fire questions and queries and ideas to us. If you're going to do this, call it SipTilSend. We're happy to share all of these materials with you, all this marketing stuff. Our Twitter feed is @SipTilSend. So if you do anything in this area, tag us on that. We've got across to a lot of people through Twitter, and it's been an absolute pleasure to give this presentation today. I'm only sorry I can't be in the room with you, but hope to see you sometime soon. Thanks for your attention, and I hope you have a very successful meeting. All the best.